We'll go ahead and get started. Ladies and gentlemen, welcome to the Michigan Immunodeficiency Foundation's first annual fall lecture. My name is Dave Sregery. I'm the Executive Director of the Foundation. I want to share some background information about myself before I continue on about our organization. First up, I am a paramedic firefighter having served in Oakland County Michigan for the last 15 years. I've owned and operated my own businesses. I have served as CEO of a local computer company and sat on board of directorship. I'm also a common variable immune deficient patient who receives IVIG. I stand here before you tonight with a new cause and challenge. That is to make Michigan Immunodeficiency Foundation a true asset to Michigan residents who suffer from primary immune deficiency. To do this, I need your support. About the Michigan Immunodeficiency Foundation, we are a U.S. corporation who have filed for a 501c3 status and are still awaiting a final response from the IRS. The Michigan Immunodeficiency Foundation's primary goal is to improve the quality of life for Michigan residents who suffer from primary immune deficiency diseases. We will achieve this goal by increasing patient and physician awareness and education of primary immune deficiency diseases and to facilitate early detection and treatment. We will raise and provide funding for research to aid in improving our knowledge of primary immune deficiency diseases and improving treatment methods. We will assist patients and family members dealing with primary immune deficiencies by providing resources, emotional support, various resources, and general assistance. Some of the resources we will be providing include lectures, online support groups, educational awareness material. Additionally, I would like to see us being able to grant some sort of wishes to our pediatric primary immune deficiency patients, such as being able to provide them with laptops and other handheld games. While these items would be theirs to keep, it would be beneficial for them during their infusions or other hospital stays. Additionally, I would like to be able to offer some sort of IVIG assistance program. This is something that we are still working on and hopefully can implement in the near future. Some of the events we are currently planning are a walk for awareness, a spring lecture in 2005 to be given by Dr. Elizabeth Secord at Children's Hospital. There will be additional events such as fundraisers and family days planned, so please check our website for additional details. Also, let me say that the Michigan Immunodeficiency Foundation has set up a new planning committee that will be working diligently to plan our upcoming events. The committee is chaired by Mrs. Pamela Colasso. Pam, if you could raise your hand for us, please. We appreciate your work very much. Pam's contact information will be also available shortly on our website. I would like to mention just a few other items. The Michigan Immunodeficiency Foundation has acquired our third position to our medical advisory board. That position is Dr. Elizabeth Secord. Dr. Secord's bio is listed on our website. Also, the Michigan Immunodeficiency Foundation is still seeking a social worker, ARN, and a doctor of pharmacology. Requirements for these positions are also listed on our website. I also need to thank our sponsors, Bayer Biological, who is our primary sponsor for tonight's event, Baxter Bioscience, where I forgot to mention at our last event was our primary sponsor, so sorry about that, Paul. And also one of our new sponsors, CLB Barron. Let me say thank you for all your support of the Michigan Immunodeficiency Foundation and your organization's commitment to the world of immune deficiencies. You guys are truly appreciated. Now on to a topic I personally don't care for and certainly don't like addressing, however, it does require some attention, that is funding. The Michigan Immunodeficiency survives on donations and grants, whether it be from corporate sponsors, other larger foundations, or personal donations. The average lecture cost is about $2,500. Our goal is to keep our events free and open for anybody to attend. Unfortunately, as we await our final response from the IRS to receive our 501c3 status, this makes getting donations extremely difficult because the donations cannot be tax deductible. So with that said, anybody who would like to make a donation, we would gladly accept it. However, I want you to be aware again that it is not tax deductible. Additionally, if anybody is interested in becoming a volunteer, please fill out an application prior to leaving tonight. Also, please make sure you sign in on our sign-in sheet located over there at the table. I'd like to thank everybody for showing up here tonight, and it gives me great pleasure to introduce tonight's speaker, who is also the Michigan Immunodeficiency Foundation Senior Medical Advisor. He holds the following titles: Division Director of Allergy and Clinical Immunology, Division Member of Infectious Disease. He is on staff at William Bowman Hospital in Royal Oak. He is also a clinical professor of medicine at Wayne State University School of Medicine in Detroit. Please help me give a warm welcome for Dr. Carl Lauter.
Very pleased to be here and see quite a few familiar faces, particularly a contingent of friends and physicians from Henry Ford Hospital. I'm a little nervous about them being here because I'm supposed to get to talk to her tomorrow and we do some of the same slides. So Bob, I'm sorry. I'm going to spend the next 35 or 40 minutes going over a topic on intravenous immunoglobulin, a little bit about its background, its use, the type of patients who receive it, because of the nature of this organization being the immune deficiency organization. I'm not going to be dwelling on a whole other group of indications for intravenous immunoglobulin, which is the immunomodulatory group of indications, such as in Kawasaki disease in children, immune thrombocytopenias, and so on. So I'm not really going to be going into that, and I believe that's probably not a topic that most of the people who are here are probably that interested in at this time. But so I'm going to be talking about patients with immune deficiency to start off, and then I'm going to tell you a little bit about the immunoglobulin treatment. And although the topic is abuse, I'm going to emphasize a little bit more than abuse. There is abuse, but in fact most of the abuse is in the immunomodulatory arm of the treatment. Most of the patients who get it for immune deficiency, it's not abused by doctors or other providers or so on, anywhere near as much. So maybe if we change the title and say use and complications of IVFG. I'd rather sort of emphasize that a little bit in today's talk. So let's get started. Okay. So when we look at the immune system, you find that the defense mechanisms are many, and some of them are called non-specific, and or sort of native immune responses, including such simple things as just an intact skin and intact mucous membranes. If there's a break in the skin or a sore on the lip, then the microbial world has access to get inside of us. So that's also important. Many of our bodily surfaces are bathed by different types of solutions, especially in the mucosal surface. So we have secretions, saliva, mucus tears. We also have a number of other mechanisms that we're really not going to dwell on in this talk, but the type of abnormalities that are seen, for instance, in alpha-1 antitrypsin problems and cystic fibrosis problems, there are ciliary dyskinesia problems, patients who have problem with mucociliary clearance, peristalsis, and things like that, which are very, very important. There are chemicals that are found in these body secretions that are not immune. For instance, things like lysozyme and other chemicals. HIV is almost never found in saliva because of natural chemicals in saliva that kill HIV. For those of you who are old enough that remember, there used to be a TV show on where Rock Hudson and Linda Evans were always kissing, and everybody wondered whether or not Linda Evans was going to get HIV because, after Rock Hudson was diagnosed with HIV, most of you might see a lot of blank stares, Rock Hudson. The fact of the matter is there's very little likelihood because of these natural defense mechanisms in saliva. Phagocytic cells are also part of the non-specific or native part of our immune system. Primary, different terms of use, and these include the polymorphonuclear neutrophils and macrophages. And we have a system of proteins that are non-specific called the complement system, which complements other aspects of the immune system. We have a number of chemicals that are secreted by cells called cytokines. If they come out of a lymphocyte, they are called lymphokines. If they come out of a monocyte, they're monokines, and so on. And these all are messengers of sorts that sometimes they actually carry out the functions that are defense-oriented. Sometimes they only carry out message functions from one type of cell to another type of cell, helping those cells or programming those cells to do something afterward. On the other side of the slide, or what can we call the more specific part of the immune system, also known as, and not on the slide, it's a whole new area of non-specific immunity that was discovered just a few years ago, called toll-like receptors. And these were discovered actually accidentally in Drosophila fruit fly, and they were actually looking at some reproductive genetic mechanisms in fruit fly, and they found by accident that endotoxin interacted with this system, and they thought, well, maybe there's something immunologic going on there as well, and the whole world opened up. In fact, I was surprised. I never knew the origin of the word toll, but this whole system was called toll by the lady German scientist who discovered this in the Drosophila. And toll in German apparently means like wow, when she realized what she had found, okay, or eureka, or something like that. Because the system is slightly different but analogous in animals and humans, other more advanced animals and humans, so they're called toll-like receptors. It turns out that they're one of the most important aspects of the initial contact of microorganisms of various types, as well as allergens of various types with our immune system, leading to eventual programming of the immune system. And that gets you on the right-hand side of the column, where we develop an active or more specific immune response. Humoral immunity, which means your antibodies, or gamma globulin, specific gamma globulin are called antibodies. Antibodies are gamma globulin proteins that recognize antigens. And antigens can be anything from a bacteria, a virus, a chemical, a piece of banana, okay, etc. And then we've got the cell-mediated or cellular arm of the specific immune system, and this is primarily lymphocyte-mediated. And the lymphocyte system is extremely complex, we now know. But for simplicity, they're usually divided into two broad categories called B and T lymphocytes. And I'm not going to go into any more detail on that, but we will talk a little bit about it when we talk about some of the individuals. So what's the definition of immunodeficiency? It's a result of a diverse group of abnormalities of the immune system which results in an increased incidence of infection. When the residents, students, fellows, etc. rotate through my immunology clinic, the first thing I emphasize is when they send them in to talk to a patient, get their medical history, I say the medical history of a patient with suspected immunodeficiency could also be called the infectious disease review of systems. So you start with their head and you work down to their toes. You can ask questions about every part of their body and whether or not they've had infections. And then, so are there ear infections, are there dental infections, are there nose infections, are there sinus, are there throat, are there skin, are there urinary, are there intestinal, are there brain, etc. And you do that from the time of birth until the point of time of their arriving in your office. And then you analyze that data, and you try to find out whether or not they are behaving differently than the general population is supposed to behave. And if you feel that they're behaving differently, meaning they have more infections than is expected of healthy people, then you're allowed to proceed and think in terms of maybe doing some tests to find out if there's something wrong with your immune system. So primary immunodeficiency means it's congenital or hereditary, and secondary means it's acquired, which can be transient. A good example of that would be you take certain medicines, but then of course of steroids, and then the steroids are gone, and then your immune system should recover after a while. Or it can be permanent, acquired permanent immune deficiency. A good example would be like AIDS. It's permanent, it improves with AIDS treatment, but it doesn't ever return 100% to normal, so it is permanent in that regard. All right, if you now look at the primary immune deficiencies, which is what we're focusing on, when we talk about immunoglobulin, you can see that as patients, providers, in various venues, and physicians in the audience, you can see where the money is when you're evaluating a person with a suspected immune deficiency, seemingly confirmed by their medical history. You can see that antibody makes up over 50%, especially if you have combined. So you have antibody alone in about half, and you've got another 20% that might be some combination of antibody and cell-mediated immunity, or antibody and a phagocytic defect, or something like that. So the fact of the matter is that most of the abnormalities are antibody. And I always like our trainees, they always want to screen the complement system, and I point out to them, screening the complement system is generally a very low yield in the beginning, unless you have specific groups that implicate the complement system, but making up less than 2%, including children and adults, of the immune deficiency. So it's not a good place to begin with the workup unless you have something very specific, which I'll get to when we talk about complement more specifically. All right, so the four major defense mechanisms then, in the more simplistic terms, would be B-cell immunity, which is that humoral or antibody, and T-cell immunity. A good example of T-cell immunity would be like HIV, although it's a mixture. Phagocytic cells, a good example of phagocytic cells that are primary, such as chronic granulomatous disease of childhood, or pediatric Gaucher syndrome, and so on. And acquired phagocytic defects would be being a diabetic, for instance. And the complement system, again, a number of places where this can be found. Associated with other diseases. Sometimes patients with lupus have C2 and C4 deficiencies in common, and they may not only have their autoimmune process, but they may also have sometimes infections. All right, so if we look at the B cells now, we're getting closer and closer to the topic. You can see that there's a number of immunoglobulins that are made by B cells, what you think of as B lymphocytes. When they are turned on, think of it like Popeye after he eats spinach. All right, turned into plasma cells, which become veritable factories to make immunoglobulin. And immunoglobulin itself is nothing but protein, but specific immunoglobulin is an antibody. It's got a target that it specifically interacts with. The immunoglobulin can interact with complement and phagocytic cells. Opsonophagocytosis means that the gamma globulin and complement help the white blood cells to engulf bacteria. So that's like putting a little salt and pepper on your dinner tonight to make it more delectable and easier for the white blood cells to ingest. IgA is a main immunoglobulin found in the secretions, such as in tears and saliva and so on. IgG has a number of subclasses, namely 4. From an immune deficiency point of view, IgG 1, 2, and 3 are the important ones, and we don't really know about the role of IgG4 deficiency as far as immune deficiency. There is a role for IgG4 in certain types of food allergies, but a lot of what we know about IgG4 is sort of mysterious. IgG1 and IgG3 are very important in defense against infection. Primarily, they're very active against viruses and proteins of various types, whereas IgG2 is very, very important as a defense against polysaccharide encapsulated bacteria, such as the important ones that cause a lot of respiratory infections, such as the Streptococcus pneumonia, pneumococcus, Haemophilus, and meningococcus as well as some others. In fact, even some gram-negatives. And IgM is the first and the original immunoglobulin. If you trace back through the vertebrate kingdom, you'll find some primitive chondrichthyes, cartilaginous fish-like ocean dwellers that only make IgM, for instance. And some of you remember back in your basic biology or in embryology class, there's an old line called ontogeny recapitulates phylogeny. And what happens is in humans and in every animal in the animal kingdom, first immunoglobulin that we make when we're little fetuses in utero is we make IgM first. And then later, as our immune system matures, there's a switching mechanism which allows B cells and plasma cells to become more diversified as they grow up, and then it can start to make other gamma globulins like A and G and so on. Now let's talk about some of the more common immune deficiencies that are seen in patients. IgA deficiency is the most common of all. In fact, it's one of the most common genetic diseases known. In the studies that were done in the 60s, where blood donors were asked if they would mind, healthy young blood donors were asked if they would mind donating a teaspoon extra of blood for research. They said okay, and the immunoglobulins were measured in these healthy donors. What they found is that approximately 1 in 500 apparently healthy donors had low IgA. Now, interestingly enough, the investigators were quite concerned when they found this, and they called these people up and they asked them, "Are you okay?" And interestingly enough, as you can see here, some patients with IgA deficient are not symptomatic. In fact, the majority of patients with low IgA are not symptomatic. Some patients who have totally absent IgA are more likely to be symptomatic than those that have partial deficiencies. However, even patients with totally absent IgA may have no symptoms of infection. And what this really points out is there's a tremendous amount of redundancy in our immune system. So if you're only low in one factor, you may actually be okay because other factors that may still be normal seem to be able to make up for that. If you're low in 2 factors or more, you're very likely that you're going to have a problem. And we'll get to that in a minute. In addition to the obvious problem, as you can imagine, of maybe respiratory infections and gastrointestinal infections, which IgA deficient patients often have, there are a number of other non-infectious complications of IgA deficiency, including autoimmune, increased frequency of autoimmune diseases, and that's actually a common theme of almost all immunodeficiencies, and increased frequency of certain types of cancers, particularly lymphomas. In addition, patients who are totally absent in IgA may develop allergy against other people's IgA, and if they're given a blood transfusion or if they're given IV gamma globulin that has IgA in it, they may develop an allergic reaction to that product. So patients who have pure IgA deficiency, we have to be very, very careful when we give them blood products. Common variable deficiency is very common and is more often diagnosed in midlife, 20s, 30s, and beyond, although there are patients diagnosed in the first year of life and sometimes for the first time at age 70s or 80s. There's a gradual, slow decline in all classes of immunoglobulin. There are also T-cell defects in many of these patients. They usually have recurrent sinopulmonary infections, so that's sinusitis, ear, bronchitis, pneumonia. They often will have chronic diarrhea, as do the IgA deficient. Again, hormonal, autoimmune, and blood disorders can also be associated. Occasionally, this will follow Epstein-Barr infection, old-fashioned mono. After they get over the mono and everything seems to be fine, and they have hypogammaglobulinemia. I've seen one patient who had this follow chickenpox. This also can seem to occur when patients are on certain medications. So anti-epileptic medications can cause a picture that is really not true common variable, but it actually is a hypogammaglobulinemic state, which is actually somehow or other caused by immune modulatory or suppressive effects of certain medicines like dilantin or tegretol or benzodiazepine, and old-fashioned phenobarbital can do it. And this is reversible Most of them don't have infection because the decreases are mild, but occasionally they actually present with infections, and then it's discovered, and then we usually have to ask their neurologist to switch them to a different anticonvulsant. Rather than give them IVIG, we would rather try to fix the underlying problem if we can. X-linked gamma-globulin was the first immune deficiency ever described. Carl Lauter was a doctor at Walter Reed Army Hospital who was testing this modern new breakthrough technique called serum protein electrophoresis. He found that this young boy who had multiple and horrible recurrent sinopulmonary infections was very sick. Very frail, very thin, always sick. Found that he had a deficiency, and eventually they decided to try to give him gamma-globulin, and was, I think, the first patient who ever received gamma-globulin as well, intramuscularly at that time. These patients with this is a definite genetic defect, almost always X-linked, primarily in males, although occasionally it can be found in females if both parents carry the gene. And all affected all classes of immunoglobulin are usually very low or totally absent, and they can't make antibody in response to vaccinations. They get a lot of infections with bacteria. Certain viral infections such as enterovirus and polio are still a risk. Luckily, there's no polio for them to be exposed to, but if these patients would be given live polio vaccine, they wouldn't get polio. Okay, but we don't use live polio vaccine anymore in the United States. Because of inadvertently giving it to people that we didn't know had immunodeficiency because they hadn't yet been diagnosed. T cells function normally in these patients. It's a pure B cell disorder. In fact, these patients, when you measure their T and B cells in the blood, you find that they don't have any B cells that can be found. Another group of conditions, which is a little bit more nebulous and controversial, but important nonetheless, called the IgG subclasses, which I already mentioned. G1, G2, G4, and these can be found in some patients. Some people are normal, and you find accidentally that they have low globulin. So having a low G1, for instance, does not indicate a disease. It's just like there are those healthy blood donors who had low IgA but didn't have any other problem. But in some patients, however, and we don't really understand why some people can get very low IgG2, for instance, and not have infection, and others have low IgG2 and have a lot of infection. Again, the two-hit theory explains it best in most people. So, for instance, patients who have IgA deficiency and IgG2 deficiency are much more likely to have infections than people who have either one alone. Patients who have partial IgM deficiency usually don't have much in the way of infections. Total IgM deficiency is incompatible with blood. If you have a partial IgM deficiency and an IgG1 or 3 or 2 deficiency, you're very likely to have a lot of infections. So combinations really explain many of the patients. Some of the other combinations are not an obvious immune deficiency. Being a heavy smoker and having IgA deficiency is more likely to get you into trouble than if you're a non-smoker with an IgA deficiency. Being a highly allergic person with an IgA deficiency, you're more likely to have sinus and ear infections than if you were an IgA deficiency and weren't an allergic person. So the two hit there is low IgA and allergy, okay, which acts synergistically to change the milieu in your nasal and sinus passageways and make you more prone to have infection. We take the medical history, which is most important, and I've already alluded to that. I basically asked about the infection history. We also take an allergy history, the reasons that I just enumerated, because allergy is synergistic with immune deficiency in those patients who have both. And we also take an autoimmune history. For those doctors in the room, what that means is it's basically a vasculitis and lupus-like review of systems. Do they have arthritis? Do they have bullous sensitivity? Do they have Raynaud's? Do they have a history of cytopenias, polycerositis, iritis? We just go for a bunch of that kind of stuff to see if there's any clues. Then we do a physical examination. The examination it can be quite limited in many patients, but you may find all kinds of abnormalities. You may find, especially in children, an absence of lymphoid tissue, when especially between ages 4 and 8, when lymphoid tissue is maximal. Almost all kids in that age have big juicy lymph nodes. If you're evaluating a youngster and you can't find any already abnormal lung findings. Patients have already had enough infections, repeated lung infections, that they may have damaged the lung and may have some conditions called bronchiectasis. You may hear a lot of noise in their lungs when you examine them. If you look at their skin, a number of immune deficiencies are associated with eczema, like rashes, so that can be a clue occasionally, and so on. And then, depending upon the history and the physical, you may elect to do some laboratory testing. So again, you ask a family history. Many of these do run in families, but not all. All right? You find out how many sinus infections. 2 or more sinus infections in a year. 2 or more months on antibiotics with little effect. 2 or more pneumonias within a year. 2 deep-seated infections such as meningitis, sepsis, or osteomyelitis. A need for IV antibiotics to clear them up if an antibiotic that don't work adequately. History of recurrent deep skin or organ infections in little babies and children, failure to thrive, and a history in children or adults of unexplained persistent thrush. Thrush can certainly occur if patients are on cortisone or they've been on a lot of antibiotics, but in little babies you can certainly get thrush without any of these, but thrush in adolescents or young adults or without an explanation should be explained. And this is modified from the 10 warning signs of immune deficiency, which was developed by the Jeffrey Modell Foundation. So let's see what those really are. The 10 warning signs, you know, we're not going to let the cancer doctors have their 10 warning signs of cancer, so we have our 10 warning signs. And they're basically the same that I just said. So again, I'm doing this for repetition on purpose, so that it's in a little bit. 8 or more ear infections, 2 or more sinus infections, 2 or more months on antibiotics without the benefit. 2 or more pneumonias within a year, and I also say 3 pneumonias in 10 years. You know, if you take a walk through Somerset Mall or 12 Oaks Mall with a microphone and a notepad, and you ask everybody you meet how many times they've had pneumonia in life, the majority of people will say never. Okay, never. So having more than 1 pneumonia automatically means something maybe problems. Failure of an infant to grow normally, recurrent abscesses, persistent thrush, especially after age 1 because of babies, it can be okay to have that. Need for IV antibiotics, deep-seated infections, bone, brain, skin, septic, and a family history. All right, when did he show up? Well, usually the phagocytic and complement and lymphocyte-mediated defects show up right away. The humoral or antibody defects don't show up appreciably later. Why? Because mother gives us a transfusion of antibody which lasts for anywhere from 6 to 8, 9 months. As a result, people with Bruton's antibody and common variable, or even some of the so-called SCIDs, which are combined severe, they may be floating in quite well for a period of time with mother's antibody. And also, if these babies are nursed, they get some T cells, and they also get the IgA antibody in the breast milk. So they can go on for quite well, but it's when the transplacental antibody is gone and we stop nursing, then suddenly they're immunologically naked and they are not making the antibody on their own, and that's when the infections will show up. So the SCIDs between 3 to 6 months, the X-linked or Bruton between 6 to 18 months, and most of the common variables and most of the complement deficiencies usually after 18 months. So again, I've mentioned we look at the tonsils, we check the lymph nodes, we look for enlarged liver and spleen, we look at the skin. When we do laboratory testing, what do? We measure their antibody, first by checking for their immunoglobulins. You may order IgG subclasses in certain patients, and if you're evaluating IgM function, let's say they have a partial low IgM, you can do something called isogluten testing, which means if you're type O blood, you should have anti-A and anti-B subgroup antibodies. They're in the IgM class. If you don't have a good titer of antibodies against A or B, or if you're type B, you should have anti-A antibodies. If you're type AB, you can't do the test. Okay. And you can do some screening of lymphocyte immunity with blood count, a lateral chest X-ray difference looking at the thymus, and a battery of the late type skin tests like Candida, DBE test, tetanus toxoid, and so on. Neutrophils, primarily we screen with a good blood smear, looked at by the hematology department. And complement, if you think that's needed, you start with a C3 and C4 and a total complement up. If you need to get into a more detailed evaluation, we do something called pre and post vaccination. Some of you, either as healthcare providers or some of you patients, may have gone through this type of testing in our office. In my office, because many of the laboratories confuse this greatly, when I try to order this test and send the patient to the lab, I had to develop my own form, which clearly the most important part of which is I do not let them run the antibody test on the first serum. They have to save the serum, and when the second serum comes in a month later, we have them run both serum on the same day in the same lab, side by side, so that that issue of variability is eliminated. Now, immune globulin primary. Antitoxins were actually first developed way back in 1890. There was a specific diphtheria antitoxin in 1897. Placental extracts of gamma globulin were actually generated in 1933. The very important technique of cone fractionation with cold ethanol precipitation was developed during World War II as part of our war effort, separating different plasma components. Treatment of agammaglobulinemia for the first time with intramuscular gamma globulin was in 1952. In 1966, plasma was used, initiated by some Europeans and also at the National Institutes of Health in the United States, as well as the Pew Select Center in the U.S. In 1969, pepsin digestion of globulin was first effectively carried out so that the product would be safely given intravenously. And in 1979, the first generation of gamma globulin for IV use became available on the market. What are disadvantages of intramuscular? I actually have one patient who absolutely refuses to take IVIG. I still give him my IM and I tell him it's not right, it's ridiculous, but he hates IV. But everybody else I have is getting high treatment. There's pain at the injection site, which also limits how much you can inject, especially in small children. You just can't give very large doses. Tissue damage if it's not properly given. The absorption is erratic. They don't reach levels. In fact, usually, even though their infection risk rates are decreased a little bit, appreciably in some patients, you can't even measure a difference before and after when you give it IM. It's difficult to achieve levels. You can't use it in patients with bleeding disorders because of the intramuscular injections. And some of the products have mercury. They still have mercury, and so there's concern about accumulation of mercury over time in these injections. What are the advantages of giving it IV, which is the standard today? If you need it, give it IV. You get very good levels. You can titrate the levels. Minimal or no pain at administration. There's very low risk of infection at the site of administration, and so on. So it's clearly the way to go. Where does this gamma globulin come from? Donor pool can be as many as 10,000 donors. You can see that if, for some how or another, as it was in the early days, the infection inactivation process wasn't as good as it is today, there was the potential, you know the old saying, one rotten apple can ruin the barrel. So one of those 8,000 people who might have hepatitis C could pass on hepatitis C to a number of recipients. That does not happen anymore because every single one of the products on the market, and for at least 10 years now, actually more than 10 years, have a number of viral and bacterial inactivation steps. In addition, for instance, there's never been a case of HIV from this because the basic cone fractionation actually kills HIV, even without any other antiviral steps. However, there were some cases in the 80s of hepatitis C, and that's been eliminated. In addition, the way donors are screened for blood transfusion is the exact way they're screened for this because this is a byproduct of blood transfusion. So they have to, everybody who donates blood has to fill out a detailed personal history questionnaire. There's a million exclusions, as you know, that's why there's such a shortage of blood, because there are so many exclusions. And then after they pass the history part of the screening, a battery of different tests are done for every known common blood transfusion transmissible infectious agent, including now even for West Nile is in the package of tests. The gamma globulin is made up of a mixture of mostly monomeric IgG, which is the stuff that doesn't cause reactions, but there's still a little bit of complexes or polymeric, which is what actually causes, for those of you familiar with this, it's occasionally in some patients, or if you infuse it a little too fast, those headaches, that are like migraine-like headaches, the chest discomfort, the feeling of shortness of breath, the achiness, that's mostly due to polymeric IgG. It's not an allergic reaction. There are some small amounts of IgM and IgA which contaminate the product. Generally, these do not cause any harm. Some of the IVIG products contain more IgA than others. In patients who have a potential for IgA allergy, there are products on the market that are low in IgA, and those are the ones that should be selected for those particular patients. The antibody content for all of these products is generally known. Each lot is sampled, and antibody content against viruses, bacteria, a number of infectious agents is assayed and is available upon request, unquote, from the manufacturer if you want this. And then a number of different chemicals of different types of products, or pH adjustment, or different techniques are used to stabilize the products to make them more amenable for stability and use. Some of the products come manufactured in liquid form, such as, I don't want to omit anybody accidentally, but Gamamune and Gamanex. The majority of products come in a powder that has to be concentrated. This is the story of the donors, which I basically reviewed with you. These are some of the antiviral steps. Cold ethanol fractionation, that's the cold fractionation. pH adjustment, trace enzymes like pepsin. Some products ultrafiltered. Some do many of these steps. Ion exchange chromatography, polyethylene glycol, solvent detergent treatment, pasteurization, such as GMRP, which is displayed over there, is pasteurization technique. That's what the P stands for in GMRP. One of the newer products are host of Bayer. I think one of the primary sponsors, Bayer, product Gamamune, and it uses a product where a chemical agent called capolate is added, which has not only good activity in activating all of those viruses, but actually it looks like we have a product that actually inactivates prions as well, which we're not sure that the other products did. So we've gone through a number of IVIG preparations, first generation, second generation, third generation, fourth generation, and I think with maybe some of the newer ones now, we might even say fifth generation. This is a complicated slide. On the left-hand column, you can see that, I hope I didn't slight anybody, but it doesn't have all the names, but you've got GMRP, you've got GammaGuard, you've got Caramune. These are all, Caramune is the ZLB variant, which also has a display here today. IVGAM is another product, which I don't think is available anymore. Legal Gamma is a brand new product available on the U.S. market now, just introduced a few months ago. It's a product that is actually made in Europe. Blood donors are all drawn here, so they draw the blood here, and they post to Europe, manufacture product, and they send it back. And this is important to be aware of because this is another one with low IgA count. In addition, Gamanex is also represented by Bayer and is the replacement product for Gamamune N, which I don't know if they're still making it anymore, but it's being phased out. So this is like the next generation of their product. I should say from a historical point of view, Caramune used to be called Sandoglobulin. It was originally made by Sandoz Laboratory, which was 12 different pharmaceutical companies later was purchased, and then eventually ZLB was making this product. And now ZLB has purchased Aventis Variant, so they actually sell both the MRP and the Caramune products. So what are some of the things that are associated with how patients tolerate these products? And how efficacious are they? Well, a lot of it depends upon the concentration, the potency, the antibody activity of the immunoglobulin. Do they have all IgG subclasses represented? How long does it last in the body? Some of them last a little longer in the body than others. Do they have good titers of functioning antibodies against all of the infectious agents we're trying to protect people against? Parenthetically, I have to remind the patients to remind their own primary care doctors that if you're on this gamma-globulin type medication once a month or once in 3 weeks or whatever, the remember to remind your family doctor that you don't need the pneumococcal vaccine anymore. Okay, first of all, by definition, if you're getting this stuff, it doesn't work in you anyway. The only vaccine that we continue to recommend to these patients, even though I'm not sure it really works, is influenza vaccine each year. And the reason we do this is because some of this stuff is shelved for many months. And the influenza antibodies are definitely in here, but they may be last year's influenza. So we tell people you're getting influenza antibodies in very high titer, and it might be right, but in case the virus has changed this year, take the vaccine too, just in case. And it may help, it may not, take it. But other vaccines, forget it. Don't let your doctor give you any vaccines. The mechanism of action is complicated, but in our patients, where you're primarily talking about immune deficiency, you're replacing that which is either missing or not working. And you can see in the left-hand side, you're making neutralizing antibodies, agglutinating, precipitating antibodies. As shown on the earlier slide, you're assisting cells to digest bacteria and viruses, and lymphocytes to kill infected cells, and so on. And then you've got a bunch of other mechanisms that have to do with the immunomodulatory mechanisms. So what do? We're primarily giving this to replace that which you don't have, or what you may have, but it's not working. Some patients have severe infections. They behave just like they're immune deficient, that they have no immunoglobulin. But when you measure the immunoglobulins, they're there. So you look at their subclasses, they're still there. You say, well, what is going on? They are like a car that looks nice and bright and shiny parked in the parking lot, and when you put the key in ignition, it doesn't go. So it's a functional abnormality of immunoglobulins. We call those patients immunoglobulin sufficient, but antibody deficient. Okay? So they have normal amounts, and if they're severe enough, they have to be given gamma globulin, which sounds strange because they have plenty of gamma globulin, but it doesn't work. So we still have to give them gamma globulin if they're really having severe infections. All right, so we use it to replace people who are low. We use it in a number of other settings. We use it in primarily B-cell disorders like Bruton's and common variable, some other disorders that are usually diagnosed in childhood like hyper-IgM syndrome, very severe illness, which fortunately is not too common. We also will use it in certain patients who have IgG subclass deficiency if their deficiency is profound enough to cause biological mechanisms. And there we go, functional antibody deficiency, and certainly some patients with other combined type disorders. IVIG is also used in some other settings. It can be used as an adjunct in the treatment of certain types of sepsis. And down at the bottom you can see that there's an increasing role in the use of IVIG in certain types of septic toxic shock syndrome, as well as some potential role in septic shock. It's used to treat certain viral illnesses. It's used to treat some patients with chronic leukemia, some of whom have low gamma globulins, and some of those may have a lot of infections, so they may have to be treated. Most myeloma patients do have a lot of infections, but we don't normally give them IVIG replacement unless they meet the same criteria as the Jeffrey Monell criteria. If they meet those criteria, they get IVIG also. Children with HIV, they've gotten the HIV at such a young age that they've never developed a series of good antibodies against a battery of normal infectious agents that most of us in adult life have already got some immunity against. So they often need gamma globulin treatment, and it's fairly routine in pediatric HIV population. It's also used in certain types of bone marrow transplant. Certain infections such as parvovirus B19, if their patients have either absent or low or non-functional IgG, it may be used as treatment for those too. In the autoimmune disorders, we're not going to dwell on these, but the ones that are most commonly used to treat are like immune thrombocytopenic purpura and certain neurological disorders such as chronic inflammatory demyelinating neuropathies or polyneuropathies, or CIDP, Raynaud syndromes, and a number of other neuromuscular disorders are considered reasonable uses. There are a number of places where it's not so reasonable. The data is not in. Multiple sclerosis is one of those controversial areas. Using it to treat Lyme disease is not appropriate. Using it to treat chronic fatigue syndrome is not appropriate. A number of other sort of a little bit off-the-wall places. In some of the autoimmune diseases, there may be a role of immunomodulatory treatment. Certain types of vasculitis, occasionally in certain types of lupus, already, there may be a role. If you have myositis, it can definitely be helpful in some situations. Kawasaki's disease is the main treatment. The main treatment is immunoglobulin. Graft versus host disease may have a role, and asthma, there was some exciting information that suggested it might have a role. The verdict is not in, but at the present time, the evidence suggests that it has a role. What are the current guidelines? Usually, we start patients off, most people with immune deficiency will require somewhere between 200 and 600 milligrams per kilogram, and most patients are given treatment approximately at every 4-week cycle. This is based on the fact that the half-life of IgG is about 22 days. So most of the time we start at 200 to 300. It says here 300. In normal, healthy young adults, that's where I start. I have some very elderly patients who are frail. I often will start even lower in those patients. We also will give a very slow infusion in the beginning because we don't know how patients are going to tolerate the product. We slowly will build up the dose based on 2 main criteria over many months. One is, are there infection frequency and severity coming under control? And number 2, what is their trough IgG level? Defined as what is the IgG level just prior to the next dose. When patients first start IVIG, they don't usually notice any difference for at least 3 to 4 months. Although some patients swear they were better immediately at 5 minutes after the infusion. More likely than not, that is more emotional than physiological. Now, there are side effects of these products. This is taken from the package insert. I'm not thinking on Gamunex, but I just happened to pick that one out. And just to mention some of the warnings, renal dysfunction, renal failure, osmotic necrosis, and death. Occasionally, patients can actually be highly allergic. Luckily, it's very rare to these products. Usually, those are people with IgA, anti-IgA allergy. They actually have specific IgE against IgA, as demonstrated by Rebecca Buckley a number of years ago in some papers that she published in the New England Journal of Medicine. Fortunately, these are very rare. There are almost always some patients who have total IgA deficiency, and so that's why we have to be very careful with those patients and use low or IgA-containing products if they in fact need to be infused. Patients with underlying diseases that have predisposed to renal damage, so pre-existing renal disease, diabetes, people over age 65, dehydrated patients, septic patients, patients with large abnormal proteins such as myeloma or CLL. They may be low in some but real high in others. They're harder to treat because they're more likely to get some of the side effects. So in these patients, the IVIG should be administered in a low concentration. So if the product, let's say, comes to 5 and 10%, you always give these people the 5%. Okay? And if it says you can go from 0.5 up to 4 milliliters per kilogram per minute, you always give them the 0.5 and you may never get above 2 milligrams per milliliter per kilogram per minute. So a certain amount of discretion is required. Some products contain sucrose, which have been associated with a little bit more renal problems than those products that don't have sucrose. Toleration is important. The Immune Deficiency Foundation carried out a study asking patients about their preferences and so on. In addition, a number of studies have shown that thrombotic complications, we now understand, can be related to their IVIG infusion. Anywhere from strokes and heart attacks, luckily these are rare, to deep vein thrombosis, and also some neurological reactions on rare occasions. If you get these almost never occur in patients who are on replacement for immune deficiency. These are much more likely to occur in patients who are given these mega doses for immunomodulatory purposes. But some people, even with the low doses, can be susceptible to these things. Adverse events. 16% of patients have had an interruption because of one or another adverse event, and 7% of patients have actually had permanent interruption because of difficulty tolerating the product. Many patients have to be switched from one product to another until they find one that they tolerate a little better. Current perception amongst hospitals and pharmacies and managed care organizations is that they're interchangeable, will give you the cheapest one you can get your hands on. That's really not correct with these products. They are very different ones from the other, and tailoring the proper product to the patient needs is actually quite important. And it's easy to give gamma globulin, but it's not easy to give gamma globulin properly, the right product, the right dose, to the patients who really need it, and not the ones who don't need it, and not giving it too fast to some and giving it fast enough to others. This is sort of the art of this field, and it's taken me many, many years, and I still struggle with this in certain patients. Patient perceptions. 57% of patients say that one of the most important factors in switching is product effectiveness. Patients actually tell us they really think that one product works better than others. The science behind this is not too strong, but there are some data, for instance, with one of the newer products on the market, Gamunex, that has been compared actually in a comparative trial with other products that actually look promising, that it might be a little more potent. 68% feel that the product wears off within 2 weeks. One of the things we ask patients when we see them for our periodic office checkups is, when do you get most of your infections when you do get an infection? If they're getting their infections primarily between the 2nd and 4th week before their next dose, that may mean that whether or not the levels seem adequate or not, that it's not lasting long enough. So the solution is either give them more and keep it at the 4-week interval, or give them the same dose and change their interval to every 3 weeks, or in some patients even 2 weeks. One of the comments came up before we started the meeting. I recently had 2 pregnant patients who went through their successful pregnancies who were on IV gamma globulin. And again, because of the marked increase in biodistribution and rapid turnover of gamma globulin in these patients, we often will shave a week and give it, if they're on 4 weeks, we give them 3 weeks. If they're on 3 weeks, we give them 2 weeks during the course of pregnancy. 58% quite well for these patients. Most of the side effects are generally mild. Most patients have very few side effects. Some of the patients are pre-medicated, as I said, the ones with bad headaches, Chemotrex. Some of the patients with who have these phlogistic aches and pains and so on, we'll give them some Tylenol beforehand. I frequently will have patients take some Benadryl beforehand. I have a couple of patients who have severe reactions, and I actually have to give them prednisone. More unusual reactions are actual or non-infectious meningitis. It's a chemical or immune type meningitis. Serum sickness, really it's like a transfusion type reaction. Actual kidney toxicity on rare occasions, anemia due to blood, red cell falling due to hemolysis. And of course, if we have IgE antibodies to IgA, we could have a severe reaction, including as severe as anaphylaxis. All right, well, I can get the aseptic meningitis with a high dose, 2 grams per kilo, as is used in these neuromuscular and other disorders. The treatment of the migraine is slow infusion, but if that doesn't work, you medicate with Tylenol. If that doesn't work, you may actually have to use specific migraine medicines. In all of these patients, slowing the infusion, sometimes changing products, pre-medicating, and occasionally using steroids. No cases of HIV ever. There were some cases of hepatitis C. There will be never again. Screening of donors and IVIG algorithms and so on is well described. This next series of a few slides is going to actually a little bit about tailoring the product to patients' diseases. Because not everybody is 10 years old and only has one disease, low gamma globulin. A lot of these patients are middle of age and elderly, and they have a number of other illnesses. And as a result, these may interact with their gamma globulin treatment and cause havoc. So volume load may be very important with people with pre-existing kidney or heart problems. Osmolality may be a problem for people who are prone to thrombosis. Sodium content could be a problem for patients who have fluid overload problems. Sugar content can be a problem, again, with some of the patients who have these neurological side effects and the thrombotic side effects. IgA content is primarily important for people who might be allergic to it. And pH has a lot to do with the stability of the product and how long it can sit there and be an active product. I'm not really going to go into these in detail, but if you look at volume load as an example, I think this is Gamunex, comes as 3 and 12%. So this is a hypothetical patient. If you had a 70 kilogram patient used at 2 grams per kilogram, the 10% formulation would be 1,400 mLs, but if you gave the 5% formulation, you'd be giving 2,800 mLs. You can imagine if you had a patient with underlying heart failure neonates or extreme elderly, other vascular or renal disease, etc., these large volumes may just not be appropriate or tolerable. So we choose the product not because the pharmacist says, well, doctor, we don't have the 12% today, we have 3%. Say, well, I'm sorry, this patient can't have the 12%. They have stuff on the bottom of this slide. Infusion rate, we really addressed. Osmolality, again, some of the sucrose products, some of these products are extraordinarily hyperosmolar, whereas other products are almost isoosmolar. And that seems to make a big difference for some patients with some of the thrombotic problems. The congestive heart failure problems, again, neonates, kidney problems, and so on. Sodium content, I think that speaks for itself. Sugars as stabilizing agents. Most of the adverse reactions, such as renal toxicity, in a study that was published, down there in MWR, from the CDC analysis and later in the New England Journal of Medicine, were the sucrose-containing products. I don't want to say anything bad about our hosts. Our hosts are wonderful. I love them. We appreciate your donations. But some of the products do have sucrose, and certain patients with underlying disease have to be careful with these products. IgA content, we discussed. pH, enough said, enough of this. Match the product to the patient. So the physician who uses these products either has to know this right in their brain, or they have to have these slides immediately handy to look up when they're deciding which product to give to which patient. So I think what the point I'm making is that these are not exactly interchangeable. And different products may be better for certain patients, although in a lot of young, otherwise healthy people, they really are interchangeable. But for patients with underlying diseases, they're absolutely not interchangeable. All right, so this is a little bit older data, but this was, this was data I generated, I think, at the end of I think like 1999 or something like that. Data in the United States, there were 17 or 18 million grams given. Hospitals were responsible for 75 or so percent. Home care companies had that 20%. I guess it's a lot more now for home care companies. And private distributors was about 5 to 10% at that time. The FDA estimated that there was a shortfall, remember, a few years ago. There's actually a shortfall again. GammaGuard production is unavailable, so Polygam is being overused because it's the other product with low IgA. So therefore, that's back ordered. And we're lucky that Flebogamma had just entered the U.S. market as another low IgA product. Otherwise, the people with low IgA would be in trouble. And we've actually had some trouble getting product for low IgA products. The Immunodeficiency Foundation estimated that as much as 50 to 75% of IVIG is actually used in this country for unapproved purposes. And a study done in New Zealand showed essentially the same thing. Now again, 1998, we used 11,000 grams of that particular, haven't really done this data since then. It's probably appreciably higher. The total cost that year was $581,000. And that, when I did this calculation, it was 1.7% of our budget, of our pharmacy budget. So it ain't a small thing at all. This was some of the comparative costs in that year through our purchasing network, VHA, Voluntary Hospitals of America Purchasing. We were able to get some product for as little as $28 a gram. Polygam through the Red Cross was $62 a gram. And when we were really short, we had to go to independent jobbers. We paid as much as $150 a gram. We were ripped off, and in fact, they were investigated by the federal government for taking advantage of this situation. These are some of the products available then. There are obviously the new ones that I mentioned. Here's some of the costs from the 2004 that I was given by our pharmacy this coming year. The MRP, 37.5. And 50 cents per gram, that's the one we currently buy through our purchasing network, so we get the best price on that. Flebogamma is $55 a gram, but we have to buy it for low IgA patients. If I can't get Polygam or GammaGuard, which is a little cheaper at $43 a gram, and GammaMune or Gamma Next now is around $54 a gram when we don't have to buy it. So they do vary quite a bit. If you think in terms of a patient's getting 20 grams and they're paying, let's say, a round number, $50 a gram, you can do the math. That doesn't include infusion time, facility charge, nursing time, and all of the other ancillaries that go with this treatment, which means that the average patient costs $25,000 a year keep them in their immunoglobulin replacement therapy. So it's a big ticket item. So cost is a factor. The cost of the product is only one part of the total cost. Acquisition cost is one part of the managing cost. It's cheaper to give it in the home than in the infusion centers, but there's costs associated with that too, because the home health providers, they have to get their fees, infusion time. You know, if you're in an infusion center, you're probably at home too. The longer the nurse has to stay, the longer they're in the infusion center, they're charged by the hour. Cost of adverse, you know, if they get side effects, if a product is cheaper but it causes more side effects, the net effect maybe it may cost you more money. If they get hospitalized, if they have to, because they get more side effects from a product, it takes them 8 hours to infuse it instead of 4 hours with another product. Obviously, that costs money that easily neutralizes the cost per gram. I'll be happy to answer any questions. Yes?
Do you routinely do an IPA level on all patients that you're anticipating starting on physical therapy?
Well, by the time a patient goes through an immune evaluation, they generally had immunoglobulins all measured. So as part of the immune evaluation, even sometimes before they get to me, their referring doctor has already done their immunoglobulins at times, and they've already demonstrated the levels. If a patient is low in IgA, but they're also very low in IgG and IgM, they usually don't have IgA allergy. On rare occasions they can. Very rare. It's usually the patients who are pure IgA deficient that are more likely to have IgA allergy, and those patients are not supposed to be treated with immunoglobulin anyway because we can't replace the IgA, and if their G and M are normal, there's no point in giving them an IVIG, and they're the ones at the highest risk. So it's usually not a big factor, although an occasional patient is a factor. I have one patient now who has severe IgA allergy, and I have to be extraordinarily careful which product I give her and how we give it. Yes?
I had one patient who's had shaking and chill type reaction twice a long time. And both of those patients is just getting over a severe infection. Does that make any sense that they occur over time?
Yeah, you know, it may be analogous to, just like when sometimes in certain infectious diseases when you give antibiotics, and you have a large organism killed, like in syphilis, you have the Herxheimer reaction, and some other diseases. It may actually be not a side effect of the product, it may be actually the product doing its job and actually affecting microorganisms. I have one patient who has terrible rhinos, and we actually give her Demerol, and it works very well. We give her 25 milligrams of Demerol. Obviously, because of that, and also some of the medication with Benadryl, she always has to have a designated driver bring her. She's not allowed to drive herself to and from the usual location. If I don't give her Demerol, usually 25 milligrams and sometimes another 25 near the end of the infusion, she will have this horrible shaking, and none of the other medications that we try to keep medication without. And we tried her on a number of products and she gets it for all of them. Yes?
Are all kind of unapproved use?
Yes. Well, I mentioned some of them. You know, some of them are actually approved on the list, but the patients don't need it. So, for instance, yes, there are certain categories of lupus and myasthenia where they actually have been studied and approved, but the specific patients in whom it's being given is like, I quote, in some practices, everybody with those diseases. That's considered unapproved. There are criteria which I'm not privy, don't have the time to dwell on, which MG patients will benefit from IVIG and which ones don't need it or shouldn't get it. Then there's a whole other category of unapproved, which are totally unapproved, meaning they're frivolous. And they're really, there's more of a lore than a literature, such as in chronic fatigue syndrome type things. Or absolutely is considered not just off-label, but just not. That's it. David?
What role do you think that a patient should play in as far as deciding possibly what sort of IVIG?
The patient, as you saw from a couple of the slides that were taken out of the IDF patient survey, the patient should play a big role. The patient has to share. Now, of course, the provider, the physician who's managing these patients, at every visit with these patients has to ask them. I usually have 3 sets of questions that I ask the patients during the visit. Number one question is, are you on schedule with your gamma globulin, and have you had any side effects? I ask them how long it took to infuse it, and if they had any side effects, what were they? I ask them if they're having trouble getting an IV stuff. I ask them. Second set of questions I ask them is, what infections have you had since I saw you last? I keep a very careful log, and if they had to be on antibiotics, and how many times they had to be on antibiotics, and how long, and was it effective? And the third set of questions are more general, and that is, of course, is anything else changed in your health status? Because I want to make sure that that they haven't developed some new illness since I saw them last that would make me want to maybe modify which globulin product. I do ask an open-ended question, but I don't ask the patient, what product do you want? Okay? Some patients are extremely savvy and have gone to the literature and the websites, and they actually do tell me what product they want, because sometimes we can't comply because their insurance company may give us a hard time on that. If it meets some of the criteria that I showed you on the slides, if the insurance company says, I want you to give this, and I say, I ain't giving that, because they have allergy to IgA, okay? Then I can usually write a letter and I can give them the back down. But if it's just emotional, I prefer this, I like this, I don't want that, if there's no medical reason, I won't prevent it. They have their own consultants. I'm one of them, for some other people. And, we have to use some judgment, and we have to be fair. There are reasons why patients should get certain products and only certain products, but a lot of patients should try to if they can tolerate all the products, they should get the ones that are less expensive. This is a very big expense. Oh, yes.
Is the product used mostly to keep patients from getting
Good question.
Does anybody ever get well or one less, or do you usually remain out of life? How does that?
Most of these diseases that we talk about are for life. Okay. However, remember I mentioned that sometimes patients can be induced by a drug, and if you discover that, you stop the drug. If the gamma globulin levels come back up, then you can stop. I had one patient who had Epstein-Barr trigger hypogammaglobulinemia. He had about 6 to 8 sinus infections a year. He had a Campylobacter gastroenteritis. He had 4 or 5 horrible gastrointestinal infections. He was hospitalized in Florida on vacation. He was hospitalized in Michigan. He was found to have hypogammaglobulinemia. It turns out that he had mono about 2 years before this started to show up. He was on IVIG replacement. He was wonderful. In fact, he's a restaurant owner in Royal. He was on IV gamma globulin for several years. At a routine checkup, I periodically check his IgG trough. Usually once a year, I'll actually check the other immunoglobulins. I said, whoa, what's going on here? Not only is your G okay, but that's fine. It should be okay because we're giving him G. I said, why does your A and M look like it's more normal today? So we waited a month, checked it again. It's kept returning normal over a period of time. His immunoglobulins returned completely normal. I took him off the gamma globulin. So some patients, it's acquired and it may be transient, so they can go up, yes. But that's the exception. Very much.
This one, thank you everybody for coming this evening. Please feel free to mingle a little bit. Stop at our sponsors. Thank you very much. Have a good evening.